today. It's quite an honor and privilege to be here. I think that I might be the only non-pediatrician up here, so hopefully next year we can invite some other specialties. I have to admit that when I saw Dr. Young's pediatric pearls, all I could think about was foreign bodies and how to take them out. So today I'm going to talk about guidelines for a pediatric myringotomy and tympanostomy tube insertion, or when to refer to your friendly neighborhood otolaryngologist. So I have no conflicts of interest to disclose. So I'm going to just review the pathophysiology and the risk factors associated with otitis media. I'd like to understand the rationale and indications for myringotomy and tube insertion surgery. I will review some of the literature and evidence of support for the current guidelines. And I'd like to gain an understanding of how to manage patients that have ventilating tubes. So as we all know, recurrent acute otitis media, which is defined as 3 ear infections in 6 months or 4 ear infections in 1 year, is one of the most common early childhood infections in Canada. It affects about 20 to 40% of children. 90% of kids have at least 1 ear infection by the time they're 1 year of age. Otitis media with middle ear effusion occurs when there's long-standing fluid in the middle ear, and it becomes very thickened and glue-like. This often occurs after an episode of acute otitis media, or if you get obstruction of the Eustachian tube. And for both of these conditions, the clinical manifestations include otalgia, hearing loss, sleep disturbance, tinnitus, and imbalance. So what are some of the risk factors for otitis media? Well, we know that we encourage mothers to breastfeed for the first 6 months because we know that there is passive immunity which is given to the infant. We need to encourage them to avoid any passive smoke exposure. There's two mechanisms whereby this causes increased ear infections. Number one, the toxins and chemicals in the smoke actually cause inflammation of the Eustachian tube and cause obstruction. Or the chemicals actually decrease the infant's actual immunity. We recommend eliminating pacifiers in older children as this creates a negative middle ear pressure in the nasopharynx. And to try to avoid multi-child daycares wherever possible. It seems to be the magic number for an increased risk of ear infections is 6 kids in a multi-child daycare. And finally, you'll want to get a dog. Why do we say get a dog? Well, in 2012, Bergroth et al. Looked at respiratory tract illnesses during the first year of life and effect of dog and cat context. This was a Finnish study. They looked at a birth cohort born between 2002 and 2005 with 397 subjects. They asked the parents to keep a weekly diary, and they also were given a questionnaire at the end of year 1. They found that children who had dogs at home were healthier. They had less frequent episodes of otitis media and tended to need fewer courses of antibiotics. And from this, they concluded that dog contacts may have a protective effect on respiratory tract infections during the first year of life. But in the end, 70 to 75% of otitis media is genetically modified due to genetics, and this is proven through twin and triplet studies. The problem is with the child's Eustachian tube, which is too short, too floppy, too horizontal, and just doesn't work. And this is according to Dr. Bluestone, who is the editor of Paediatric Otolaryngology, which all otolaryngology residents know inside and out by the time they hit their exams. So what is Eustachian tube dysfunction? Well, the Eustachian tube is a fibrocartilaginous tube that connects the middle ear cavity to the nasopharynx, the function of which is to aerate the middle ear and facilitate secretion drainage from the middle ear to allow for normal hearing. So normally the Eustachian tube is a closed structure, but it opens whenever there's movement of the mandible or the pharynx. So that's when you're in an airplane, you feel like your ears plug, you want to yawn and swallow. That opens up your Eustachian tube. And what causes Eustachian tube dysfunction is any condition that prevents the Eustachian tube from opening. And this results in Eustachian tube dysfunction. So surgical treatment for Eustachian tube dysfunction is myringotomy and tympanostomy tube insertion. This is where we make an incision into the eardrum and insert a ventilating tube into the incision to drain the fluid and ventilate the middle ear. Once the tube goes in, it stays in for about 1 to 2 years and then eventually falls on its own. The purpose is to improve the hearing, reduce risk of recurrent acute otitis media and recurrent effusions. And MNT, or tube surgery, is the most common reason for a child to receive general anesthesia and undergo ambulatory surgery in North America. It's estimated that there'll be about 700,000 operations in the United States. Now, in 2016, the FDA put out a warning to say that general anesthesia in children under 3 years of age that are exposed to prolonged or repeated general anesthesia may have an impact on brain development. And so now parents come in and they've scanned the internet, and this is a question that they often ask. In the United States, of course, they have looked into other alternative methods. So Dr. Rosenfeld, he's the chair of otolaryngology in Brooklyn at SUNY, and he published a study of his series of office insertion of tympanostomy tubes without anesthetic in young children. So to date, he's had about 300 cases, and he's offered this to parents as an alternative to GA. 90% of the kids were less than 2 years of age. There was no serious or significant complications reported, no difference of parent perception of recovery, satisfaction, or post-procedure nightmares, bad memories. And he reported no differences in tube patency or duration. And apparently all children and parents tolerated the procedure well. So in 2019, the American Academy of Otolaryngology, where we get most of our guidelines in the otolaryngology community, put out a statement that although insertion of tympanostomy tubes in children is generally accomplished in the operating room under general anesthesia, insertion in the clinic is in appropriately selected patients using shared decision between clinicians and families can be appropriate. Now, in order to achieve this, we need something called protective stabilization. What the American Dental Academy Paediatric Dentistry has been using this term since 1990. You might know it better as patient restraints or medical immobilization, but this is the term that they use. And here's a picture of a child undergoing tympanostomy tube in the office without anesthetic. You do need to have the child in protective stabilization with a pampooz, and you need a very well-trained assistant. Apparently, Dr. Rosenfeld can do this procedure in 4 minutes on average. So, what are the indications for tympanostomy tubes for recurrent acute otitis media? Well, you can divide that into with or without a middle ear effusion. So we follow the American Academy of Otolaryngology guidelines, and the latest guidelines are 2013. If they do not have a middle ear effusion, generally clinicians should not perform tympanostomy tube at the time of assessment for candidacy. However, if they do have an effusion, either unilateral or bilateral, then clinicians should offer tympanostomy tube insertion. Well, what's the evidence for this? So in 2019, Levere et al. Published in the International Journal of Paediatric Otolaryngology, watchful waiting for children with recurrent acute otitis media without effusion. They did a chart review of 123 children aged 6 months to 12 years with recurrent acute otitis media without middle ear effusion. They followed these kids every 4 months with watchful waiting, and they found that there was a 66% rate in avoiding tympanostomy tubes, but a 34% failure rate, eventually requiring tube insertion. And they concluded that the 2013 American Academy guidelines were appropriate. So what about for otitis media with effusion? So if the child has bilateral effusion for 3 months and documented hearing difficulties, then MNT should be offered. If the child has unilateral or bilateral OME for 3 months and symptoms likely attributable, such as balance problems, poor school performance, behavior problems, ear discomfort, or reduced quality of life, we can also offer tube insertion. And finally, if they have unilateral or bilateral effusions and they're an at-risk kid, and if the audiogram shows a flat type B tympanogram, then also we would offer a myringotomy tube. So who are these at-risk children with otitis media with effusion? Well, these are kids that have some underlying hearing loss, such as congenital sensorineural hearing loss, which is independent of otitis media with effusion. If they have any either suspected or diagnosed speech or language delay, if they are on the spectrum of autism, any craniofacial disorders, any type of visual impairment, cleft palate, or developmental delay. So one of the first things that parents ask me if we get into the discussion of putting tubes in is, does my kid need to wear earplugs when they go swimming? Well, according to the guidelines in 2013, routine prophylactic water precautions should not be encouraged when children with tympanostomy tubes, i.e., they do not need to wear earplugs when they swim. So what's the evidence for this? Well, Subtil looked at the effect of water precautions on otorrhea after tube insertion. They did a randomized controlled trial with 244 subjects aged 2 to 10 years. The incidence of otorrhea was not different with or without prescription of ear protection during water exposure among these children with tympanostomy tubes. Steele et al. Did a meta-analysis, a review of 25 articles published in Paediatric 2017 looking at prevention and treatment of tympanostomy tube otorrhea. There was no compelling evidence for a need for water precautions. And then here at Sick Kids in Toronto, Chang and James also looked at water precautions for prevention of ear infections with children with grommets. They did a Cochrane review, and only 2 RCTs met the inclusion criteria for their review. They did find some evidence to suggest that earplugs would reduce the rate of otorrhea in children with ventilating tubes, but the absolute reduction in numbers of episodes of otorrhea was very small and unlikely to be clinically significant. So the kid would have to wear, based on the data that they got, an average child would have to wear earplugs for 2.8 years to prevent just 1 episode of otorrhea. But there are some caveats to water precaution guidelines. If they're swimming in lake water, sometimes there can be other types of bacteria there, such as Pseudomonas. So you'd also be concerned about swimmer's ear, which is quite different from otitis media. And some of these kids, actually, the parents tell me even before we discuss tubes that they've got a history of ear pain or otorrhea. So these kids, I would also recommend putting in earplugs. Also, if they are diving more than 6 feet underwater, then that pressure is great enough to push the water into the mid-ear through the patent ventilating tube. And then finally, I recommend avoiding dunking their head in the bathtub. Why specifically in the bathtub? Well, different types of fluid have different types of permeability. And Ungar and his group they did a tri-dimensional model for ventilating tube permeability. They used 3D printed models of the external atrisk canal, and they assessed the permeability of the ventilating tube to different types of liquids. This included water, soapy water, and dexamethasone. And most of these solutions required a volume that was at least as high as the volume of the external atrisk canal in order to provide enough pressure to pass through the ventilating tube. But what they found was soapy water had the highest penetrance and required the least volume in order to pass through the ventilating tube. Now, with ear infections, sometimes we discuss adenoidectomy. And if a child is under 4 years of age, generally we don't recommend adenoidectomy unless there is a distinct indication that exists, such as nasal obstruction or chronic adenoiditis. In a child 4 years of age or older, clinicians should recommend tubes and adenoidectomy as well. And what's the evidence for this? Well, Bunacker looked at adenoidectomy with or without grommets for children with otitis media. And he did a review of 503 articles, including 10 trials. The primary outcome was failure at 12 months. They found a small beneficial effect in children less than 2 years of age with recurrent acute otitis media. And they found that adenodectin was most beneficial in children with otitis media with effusion greater than 4 years of age. They found they had 50 days less effusion and a 90% lower failure rate. So this illustration shows ear infection with and without tubes. So you see in the top picture, the eardrum is bulging. And this is where the pain comes from, because the eardrum is exquisitely sensitive. In the bottom picture, you see the pus coming out of the ventilating tube. So this often happens. You get some discharge from the ear after ventilating tube insertion. So what do? So again, going back to Steele and al.'s meta-analysis, their evidence supports topical treatment of acute uncomplicated tube otorrhea in preference to watchful waiting or oral antibiotics. Van Dongen from Amsterdam did a trial of treatment for acute otorrhea in children with tubes. They did a multi-center RCT of 230 children. At 2 weeks, just using antibiotic or steroid eardrops, only 5% had persistent otorrhea. With oral antibiotics, only 44% still had otorrhea, and for just watchful waiting, 55% continued to have otorrhea. So the American Academy guidelines recommend that clinicians should prescribe topical antibiotic eardrops only without oral antibiotics for children with uncomplicated acute tympanostomy tube otorrhea, and this is consistent with the 2013 guidelines. So what is the clinician's roles for Myrin-Godwin tube for otitis media? Well, we need to educate families to mitigate those modifiable risk factors, utilize the current guidelines when discussing management options for acute otitis media and otitis media with effusion, discuss all the potential risks and benefits associated with all treatment options offered, and also to support a shared decision-making process. Thank you.